Good evening, all. Welcome to Journal Journey. We welcome all the dignitaries as well as delegates who have joined here live as well as on YouTube. Today is 1st December. It is World AIDS Day. The first case of HIV/AIDS was diagnosed in USA in 1981. And we have started, WHO has started commemorating from 1988. And we got control over this problem in 2007. This is only possible because of science. And our journey, Maharashtra IIP with Raigad IIP, is having pure academic feast for last 3 years. Now, may I request our star member and Raigad IIP editor, Dr. Neha Singh, for a formal welcome. Over to Dr. Neha.
Thank you, Chitra ma'am. Good evening, everyone. And on behalf of Maharashtra IIP as well as Raigad IIP, I, Dr. Neha Singh, welcome you all for today's journal journey. In absentia, I welcome Maha IIP President 2024, Dr. Ram Gopal Chezara, Maha IIP Secretary General and Central IIP EB, Dr. Amol Pawar sir, Maha IIP President 2025, Dr. Sanjay Pakmore sir, as well as all the respected executive board members. I also welcome Raigad IIP President Dr. Vikas More, Secretary General Dr. Ajay Kohli, respected Dr. Niman Mohanty sir, past President Maha IIP Dr. Hemant Gangolia sir, Dr. Jay Bhandarkar sir, and Chitra ma'am, and all the members from Raigad IIP as well as other branches. We request our attendees to please post their queries in the chat box, and we will take them at the end of both the articles. And now Vikas More sir is there?
No, ma'am. Not yet.
Okay. So friends, for today's session, we have two experts with us. Pallavi ma'am, please share the slides. Our first expert is Dr. Anand Itkar sir. Sir is consultant pediatrician at Kalyan, Mumbai, formerly Honorable Consultant Neonatologist at Wadia Hospital, Mumbai. He runs tertiary care NICU at Kalyan for 25 years. His special interest in respiratory care in neonatology. He is pioneer in point of care sonography in neonatal care. Our second expert is Dr. Amol Chevre sir. He is consultant pediatric infectious diseases and transplant ID. Sir is a consultant at SRCC Children's Hospital Mumbai, Jupiter Hospital Thane, Surya Children's Hospital Chembur, and CTC PHO BMT Center Borivali. Sir has special interest in transplant ID, topical infections, critical care ID, and antimicrobial stewardship. Sir has 7 publications in index journals, 4 original articles, 3 book chapters, and 2 IIP guidelines. Our first speaker who will present the article is Dr. Ankita Mate. She is consultant pediatrician at CDH Panvel, consultant pediatrician also at Kids Clinic Panvel. She was ex-medical superintendent at CDH Roha, and she will be presenting the article, The Association Between Breastfeeding and Growth Among Infants with Moderately Low Birth Weight, a Prospective Cohort Study. While our second speaker is Dr. Yasha Parmar. She is DNB student at Leelavati Hospital, Mumbai. And she will be presenting the article Monkeypox, a Comprehensive Review. So I welcome all of you for today's session. And now I request Dr. Ankita Mate to please share her slides and start the session. Over to you, Dr. Ankita.
Thank you, Dr. Neha.
Please switch on your video.
Yes, ma'am. Are my slides visible?
Yes,
Yes.
it's
Yes.
please make it full screen. Yes.
Good evening, all. Myself, Dr. Ankita Mate, consultant from Panvel. Today, I am going to present an article, The Association Between Breastfeeding and Growth Among Infants with Moderately Low Birth Weight, which is a prospective cohort study. This was published in volume 26 of the Journal of Pediatrics in June 2024. The authors of this article are Kristen North and et al. Breastfeeding, as we all know, is associated with many benefits, especially for the low birth weight infants who are more vulnerable with high burden of morbidity and mortality. The process of establishing breastfeeding is often the most difficult for this population. This study is unique because there are no previous studies which have compared preterm infants with term SGA. There are no studies which have evaluated breastfeeding competency among the discharged low birth weight infants. Most of the previous studies have evaluated the admitted or in low birth weight infant which were hospitalized. There have been no studies which correlated latch or PIP score with the longitudinal growth among the infants with low birth weight. Early latch score and 6 months breastfeeding exclusivity was not evaluated earlier. Association between PIPs and exclusive breastfeeding has not been evaluated. Also, most studies have limited to the early growth metrics. This study is unique because it has evaluated the growth metrics till 6 months of age. We'll quickly have a look on the breastfeeding assessment scale which are used in this study, the latch and PIP scale. This is the latch scale, which scores the mother-infant duo on a 10-point scale. L stand for latch, A for audible swallowing, T for type of nipple, C for comfort, and H for hold. The mother-infant duo is scored from point 0 to 2 in each characteristic, and the total score is 10. This is the PIP score. The scale items in this PIP scale are rooting, areolar grasp, latch on and fix to the breast, sucking, longest sucking burst, and swallowing. The infant in this scale is scored from 0 to 1, 0 to 0, 1, 2, and so on in each scale item. The total score is 20 points. So both these scales are very easy and can be done by all the clinicians. The objective of the study is to describe the breastfeeding competency score first 6 weeks of age to assess the association between early breastfeeding competency score, latch and PIPs, and exclusive breastfeeding at 4 and 6 months, and infant growth at 6 months among the infants with moderately low birth weight in India, Malawi, and Tanzania, which are the low middle income country. The study design, the latch and the PIP assessment was conducted among the mother and infant duo enrolled in the low birth weight infant feeding exploration life observational study of the infants with moderately low birth weight 1500 grams to 2499 grams. Breastfeeding observations were conducted as a part of the life study, an observational cohort study conducted across the 12 hospitals at 4 sites in India, Malawi, and Tanzania. Low birth weight infants were enrolled from the postpartum units or NICU within 72 hours of birth. This was a 6 months prospective cohort study conducted from 13 September 2019 till 27 January 2021. The sample size of this breastfeeding cohort, the number of infants among the 1,114 enrolled in the life prospective cohort who were observed to be the breastfeeding during a routine study visit in the first 6 weeks of after birth, week 1, 2, 4, or 6 of age, were enrolled in this study. Total number of 988 mother-infant diets were observed for breastfeeding in this study. The inclusion criteria were moderately low birth weight infants, less than 72 hours of birth from postpartum units or intensive care units. exclusion criteria: congenital anomalies affecting feeding, severe neonatal encephalopathy, young mothers, infant with twins who died before 72 hours, infants with mother whom plan to move away from the catchment area. The low birth weight infants were classified into 4 groups: preterm AGA, birth weight less than 10th percentile; preterm SGA, birth weight between 10th to 90th percentile; preterm LGA, greater than 90th percentile; and term SGA. This is as per the Intergrowth 21st standard. The methodology: baseline demographics were noted down at the start of the study, antenatal history was taken, birth weight was noted down, and breastfeeding assessments were done during a study visit. Questionnaires from the Latch 10-point scale and PIPS 20-point scale were undertaken. Anthropometric assessment was done at enrollment week 1, 2, 4, 18, and 26. The data reporting was done based on feeding patterns at 4 and 6 months of age. Breastfeeding assessment was a direct observation of breastfeeding session by a trained nurse or a clinician. Assessment composed of questions from the Latch and PIPS tool. For Latch, mother-infant diets were scored on 10-point scale, and for PIPS, infants were scored on 20-point scale. We'll look at the definitions which have been used in this study. Regaining birth weight, that is meeting or exceeding birth weight by 2 weeks study visit. Slow week 2 growth weight gain. Average weight gain under 20 grams per day. Underweight, weight gain, weight for age Z score less than -2. Weight gain velocity, change in weight for age Z score from baseline to the measured time point. And exclusive breastfeeding, feeding only human milk at all the data collection visits. The result: the data was collected from this 6 months prospective cohort study and was analyzed. This was as a part of life study. In the life study, the 2,152 infants were assessed for eligibility and 1,982 mothers were assessed. After a few infants, like 1,026 infants were excluded from this life study due to unknown time of birth, mother not alive during screening, infant not alive during screening, mother too young, lives outside catchment area, 6 months follow-up not feasible, birth weight unknown, birth weight less than minus 1.5 kg or greater than 2.5 kg, twin died, congenital anomalies, and asphyxia. So the total number of infants enrolled in life study were 1,126 and mothers 1,081. A few infants were excluded from analysis, 12 due to administrative withdrawal or death within 72 hours. So the total number of mother-infant diets which were observed for breastfeeding were 988. So this table shows the demographic of the low birth weight infant feeding exploration cohort mother and infant with latch and PIP score. The maternal demographics were maternal age, secondary education, parity, married, maternal HIV positive status, and feeding counseling. So in this study, the average maternal age was 25.4 years. 54% of mothers enrolled in the study had received education more than secondary education. 94% were married. 42% were parity 1, 27 with parity 2, and 26 with parity 3 plus. 26% or 21% of mothers had a previous low birth weight. 5% of the mothers enrolled in this study were HIV positive. 78% had received breastfeeding counseling at baseline, and 98% of the mothers had received antenatal care. Antenatal care teaching was also received by the mothers. 53% of the mother received exclusive breastfeeding for 6 months, and 25% breastfeeding position and attachment, 14% expression of milk storing, 23% breastfeeding on demand, 33% benefit of breastfeeding, and 11% KMC. Okay. This shows the infant demographics. 45% were male child, and 31% were born by cesarean section. The average birth weight in this study was 2.1 kg. The average gestational age was 37 weeks. 54% of the infants enrolled were term SGA, 13% were preterm SGA, 29% were preterm AGA, and only 3% were preterm LGA. So this study compared 949 mother-infant diets with at least one latch or PIP score to 121 without breastfeeding competency score. Mothers without competency score were less likely to exclusive breastfeed at 6 months. That is 21% versus the 46%. This table shows the association between week 1 continuous latch and PIP score and exclusive breastfeeding at 4 and 6 months. Among the infants with breastfeeding observation, 61% were exclusive breastfed at 4 months and 46% at 6 months of age. Neither latch nor PIP score were at week 1 was associated with exclusively breastfeeding at 4 or 6 months. Among the infants with breastfeeding observation, 20% did not regain the birth weight by 2 weeks, 33% had low growth weight velocity. For every additional point on latch or PIP score, there was lower likelihood of being underweight. So this table shows the association between week 1 continuous latch and PIP score and the growth metric. Among the latch score at week 1, 118 did not regain birth weight by 2 weeks. 482 infants regained birth weight by 2 weeks. 412 infants had a slow growth velocity. 118 had growth velocity greater than 20 grams per day. 131 were underweight at 6 months, and 377 were not underweight at 6 months. PIP score at week 1, 144 did not regain by 2 weeks, birth weight by 2 weeks. 625 did regain the birth weight by 2 weeks. 533 had slow growth velocity. 237 had velocity greater than 20 grams per day. 194 were underweight at 6 months, and 494 were not underweight at 6 months. So this figure shows the association between the latch and the PIP score and the weight gain velocity. The figure A shows the latch score, and it is more the latch score were at week 1, 2, and 4 and 6 were positively associated with weight gain velocity at 1, 4, and 6 months. The figure B on the right side shows the PIP score and beta coefficient. This figure shows that PIP score showed positive trends in weight gain velocity. The results: there was no association was found between latch or PIP score and rate of exclusive breastfeeding at 4 or 6 months. Higher week 1 latch and PIP score were associated with increased likelihood of regaining birth weight by 2 weeks of age. Higher PIP score at 1 week were associated with improved weight gain velocity at 1, 4, and 6 months. PIP score at week 4 were positively associated with change in weight for age Z score from birth to 4th and 6th month of age. This study shows there is improved early breastfeeding. If there is improved early breastfeeding competency, which is suggested by a higher latch or PIP score, it was associated with improved growth in early infancy. Breastfeeding competency improved throughout the first 6 postnatal weeks. Term SGA will benefit from specialized lactational support. There is no association between LBW type and breastfeeding. So this latch and PIP scale can be used to identify high-risk infants for targeted lactation support. So a clinician can prioritize limited lactation resources in resource-constrained settings. The strength of the study, it is a prospective cohort study, so more reliable. There is novel association between early feeding competency and later growth. Direct breastfeeding observations of infant with low birth weight in low middle income countries. breastfeeding observation data was done up to 6 months of age. The limitations of study were related to the latch and PIPs. The sessions, breastfeeding sessions were not coordinated, and so data collection with breastfeeding sessions was not done. Loss of follow-up and missing data due to COVID pandemic. Thank you.
Now I invite Dr. Anand Hitkar sir for his expertise comments. Over to you, sir.
Good evening, all. Thank you, Dr. Ankita. So nice presentation. And it's great to share with Ankita because we worked together a long time back, nearly 10 years back. Ankita and myself worked together in Kalyan.
Yes, actually,
Uh,
one thing I would like to share that I started my career in pediatric, like private pediatrics with you only in 2010. And also now when I'm restarting the academics, so I'm with you again for the first time. That's great for me.
Great. See, I mean, mainly in practice of neonatology from last 25 years, and the area which we are struggling always is a assessment of a breastfeeding in a preterm babies and low birth weight babies. It's always a subjective criteria on which we judge. We keep on asking sisters whether the suck is good, feed kartoy ka vyavasthit. We ask mother that whether baby is sucking well. But there is no objective criteria or objective scoring system on which we are judging for the adequacy of breastfeeding. So I have gone through some data where the exclusive breastfeeding or breastfeeding data in a preterm and low birth weight, there is a lot of variability from institution to institution. And we need to have some consensus about these things. So assessing how much breast milk baby has ingested while breastfeeding is a very difficult task. So all neonatology people tend to give a supplement this feeding with her vati and spoon feeds of a EBM. And with that, we end up in sometimes overfeeding a baby or underfeeding. Overfeeding causes sometimes metabolic syndromes, and underfeeding causes the loss of weight gain, or weight gain is not adequate. And this spoon feeding undermines the confidence of breastfeeding of a mother. And this again reduces the low latching rates. So to cover this paper has really given a very good guidelines on two very validated scores, that is latch score and PEEP score. Latch score is mainly, whatever I have gone through the previous papers, that latch score is mainly related to the term babies, where latching, audible swallowing, type of nipple comfort and holding, all these parameters which Ankita has already told, and 0 to 10 is a scoring system. Every number had a 0, 1 and 2 scores, so total score was 10. And anything scoring more than 7 was considered as a good score. In PIBS, where we really struggle in neonatology, that they have given importance to latch quality, sucking, swallowing, coordination. Sucking and swallowing coordination is really a crux of the feeding in these babies, because sucking, swallowing coordination do not happen up to 33 to 34 weeks. Until that time, we struggle for feeding these babies. And so if some baby is coming to us at around 27, 28 weeker and not adequately feeding up to 33 weeks, it is really difficult to because our practice is mainly a cost conscious. All parents are always worried that baby should feed much faster. So till date, we do not have any data on which we can objectively score how baby is feeding. But with this study, or with these two scoring systems, we can definitely go for the assessing breastfeeding practices on an objective way. regarding this paper, this is a really good paper where two validated scoring systems has been used in a two different environmental collecting points, that is a middle income group, that is India, and low income group, that is African, Malawi and Tanzania. The sample size for this is a reasonably good sample size. Around 1,000 babies, 988 babies were enrolled. That is a good number. And from the robust different geographic area. And this is a longitudinal data collection is almost for 8 to 9 months. And this is a prospective study, not a retrospective study that improves the outcomes. And they have validated these two tools, that is Latch score and PIP score. The flip side of this paper is there is a no good correlation between the first week latch and PIP score and exclusive breastfeeding practices for 6 months, which, if we are thinking logically, this should be correlating. We really need to analyze why this has not happened. Because I have searched for some other papers in this also, but I couldn't get similar studies in past. Another flip side is that this study has not was disrupted in between due to the COVID pandemic, and so the data analysis, data collection might have reduced. Third is they have concentrated mainly towards but preterm is a lot of variable areas, that some babies are 26 weeks to
सर डिस्कनेक्ट हुए क्या?
नेटवर्क प्रॉब्लम.
नेटवर्क प्रॉब्लेम दिसतोय मॅम. लॉग आउट झाले आता सर.
Chitra ma'am, you unmute please.
Madam, please unmute. Chitra, unmute करा.
Sorry, there was some technical issues. Should I continue or the time is up? I think almost I have done.
Please conclude.
Hello. Yeah.
Please conclude.
So,
No problem.
yeah, flip side of this was related to the they are not much given a concentration to the preterm. So we need to have more studies only regarding to the preterm, because preterm is a very diverse group. Overall, this study is a very provides a very valuable insight for the. Thank you so much.
Yes, sir. Thank you. Thank you. Thank you, sir.
Madam, any question this chat box
We
so that
will,
you can.
sir, we will have a second topic now.
Okay.
Can we have second topic now?
Yes, yes. Yeah.
Yeah. Dr. Yesha?
Yes, ma'am.
Yeah, please start your presentation.
Yes.
Hmm.
My slides are visible.
Yes, ma'am.
Good evening, everyone. So I'm Dr. Yesha from Lilavati Hospital. I shall be presenting in today's journal journey a review article on monkeypox, which is published in MDPI Journal Volume 14 on September 2022. So this review provides a comprehensive overview of the monkeypox, covering the epidemiology, the trends and spread of the outbreak, the characteristic of the mpox virus, mechanism of infection and disease progression, the clinical features, how to diagnose the cases of mpox, management, the treatment and care strategies, and preventive and control measures, recent advancement in vaccine development, and future research directions. The multi-country outbreak reported by WHO of this mpox virus in May 2022. According to current statistics, there are 103,048 confirmed cases and 229 deaths globally as of July 31st, 2024. There are 500 laboratory confirmed cases in children and adolescents worldwide. Causative agent is mpox virus, identified for over 60 years and first report in 1959 detailing outbreaks among the Macaca fascicularis monkeys. Initially, first human case is recognized in 9-month-old child in the Democratic Republic of the Congo in 1970. And endemic regions are primarily reported in the Central and Western Africa. First contributing to outbreaks is a post-smallpox vaccination. There are increased susceptibility after the cessation of the smallpox vaccination, 85% effectiveness against the monkeypox virus. And there are certain environmental and social factors will increase the there will be increased animal consumption, population density, and ecological changes are contributing to outbreaks. Monkeypox virus are from orthopox virus within the poxviridae family, alongside variola, cowpox, and vaccinia viruses. Distinctive feature is mpox virus has its broad host species tropism, which includes a range from rope squirrels to sooty mangabes. This diversity may facilitate the prolonged zoonotic circulation of the virus in the wild. First isolation in 1958 from cynomolgus monkeys. This is the morphology of the mpox virus. It has a ovoid or rectangular brick shape, typically measuring the 200 into 250 mm size, decorated by the membrane surface tubules or filaments, along with a biconcave core. It has a linear double-stranded DNA over 197 kb and contains around 200 genes and ends covalently closed by inverted terminal repeats. It has a unique life cycle. Replication occurs exclusively in the cytoplasm. It does not interfere with the host genome, and it is distinct from the other DNA viruses. There are two clades of this monkeypox viruses. First, it has a subclades 1A and 1B, which is formerly known as a Congo Basin strain, and clade 2 also has a subclades 2A and 2B, which is formerly known as West African strain. Phylogenetic analysis indicates the 2022 outbreak primarily linked to clade 2B strain, and most pediatric case reports describe infection with clade 1 mpox virus, which has been associated with greater severity and a higher case fatality rate than clade 2. In the pathophysiology, this mpox virus enters through the oropharyngeal and nasopharyngeal routes, intradermal transmission, via sexually transmission, and vertical transmission. In human to human transmission, there will be a direct contact with the infected lesions or mucosa. It can transmit through respiratory droplets and through contaminated materials like clothes and utensils. This figure shows the pathophysiology of this monkeypox virus. Uh, After inoculation, there will be the integration between the molecules on the viral coat and the receptors on the human cell membrane. This entry will facilitate by the A16, 21, 28, G3, G9, H2 like proteins, and viral entry in the host cell, replication and circulation to lymph nodes, draining the mucosa. It will cause the primary viremia, and it will lead to lymphoid organ and distant. It will goes to lymphoid organs and distant lymph nodes like spleen, and viral replication will occur there, and it will lead to secondary viremia. And after that, clinical manifestation of monkeypox, including skin and tertiary organ, will appear. In clinical characteristic, this mpox virus symptoms are similar to smallpox but vary by the virus clades and settings. There will be fever, rash, malaise, myalgia, headache, sore throat, and lymphadenopathy will be there. In asymptomatic cases, serology studies in Cameroon show high levels of orthopox virus IgG and IgM in asymptomatic individuals, that will indicating the possible asymptomatic infection. Mpox virus has incubation period of 5 to 21 days. There are two phases of infection. First, invasion period is from day 1 to day 5. The symptoms include chills, fever, sore throat, headache, myalgia, and lymphadenopathy. And second phase is skin eruption period that will begin 1 to 3 days after fever, progressing through the macular, papular, vesicular, pustular phases. And lymphadenopathy is a hallmark of monkeypox, differentiating it from the smallpox. Typically, it will appear 1 to 3 days after fever and can be unilateral or bilateral and may be painful. The common site involved are submandibular, cervical, axillary, or groin lymph nodes. And skin eruptions lesions evolve over 1 to 2 days, starting as a macules and progressing to pustules. Initial lesions appear in the mouth and then on the face and extremities. Lesion size are usually 2 to 10 mm, characterized by hard and thick texture. This picture is showing the various type of skin lesions. Macules visible on first 2 days, and then it will evolve into papules, then vesicle, pustules, and scab. These are the indicator which is showing the need of hospitalization. If lesions are 100 or more than 100, adenopathy will be there, mouth sores, dysphagia, nausea, and vomiting. This is the difference between the different type of viral rashes. So first is a monkeypox virus has incubation period of 5 to 20 days with prodromal period of 1 to 4 days and rash period of 14 to 28 days with fever, lymphadenopathy, lesions on the palms and soles, and lesions are appeared firm or rubbery and deep vesicles, well circumscribed and umbilicated. In chickenpox rashes, there will be no lymphadenopathy and rare lesions on the palms and soles, and lesion will be superficial vesicles surrounded by the irregular erythema. Dewdrop on rose lesion will be there. In hand, foot, mouth disease, there will be fever but no lymphadenopathy, but palms and sole has the lesion. Lesions are small vesicles 2 to 8 mm with elongated on the erythematous base, and in the measles, the fever will be there, but there will be no lymphadenopathy and rare lesions on the palms and soles, and characteristic of lesions are maculopapular rash and non-vesicular rash will be there. Diagnosis, the medical history and clinical assessment. Key elements in the history taking will be travel to endemic areas, interaction with wild animals from infected regions, care for infected patients, and clinical appearance assessment is crucial. The monkeypox case definition is like we will call the suspected case when sudden onset of high fever followed by a vesicular pustule eruption presenting predominantly on the face, palms of the hands, and soles of the feet, or the presence of at least 5 smallpox type scabs. Confirmed case is a suspected case with laboratory confirmation with positive IgM antibody, PCR, or virus isolation. Probable case is a suspected case with no possibility of laboratory confirmation, but with epidemiological link to a confirmed case. And possible case is vesicular, pustular, or crusted rash not diagnosed as chickenpox by the family or the healthcare provider. History of fever and vesicular or crusty rash. An individual met one of the epidemiologic criteria or demonstrated elevated levels of orthopox virus specific IgM and had unexplained rash and fever and more than or equal to 2 other signs or symptoms from the clinical criteria. Common laboratory finding will be elevated transaminases, low blood urea nitrogen, hypoalbuminemia, leukocytosis, thrombocytopenia. Elevated ALT and AST are the predictors of the poor prognosis. The laboratory testing modalities are: first is a real-time polymerase chain reaction. It is a gold standard for detecting the mpox virus. Specimens can be taken from the lesion, exudates, or scabs. It is based on the nucleic acid amplification test that demonstrates the monkeypox DNA. Other laboratory methods will be virus isolation, immunohistochemistry, IgG and IgM enzyme-linked immunosorbent assay, electron microscopy. These methods require specialized facility and proper biosafety measures. So mpox virus as a differential diagnosis are varicella virus, measles, molluscum contagiosum infection, cutaneous bacterial infection, scabies, syphilis, drug allergies, and notably lymphadenopathy during the prodromal phase helps to differentiate between the monkeypox from the varicella and variola, as we discussed. Non-infectious conditions like Behçet disease, squamous cell carcinoma, and recurrent abscess stomatitis. In the treatment of monkeypox virus, we can manage the mild and uncomplicated monkeypox virus with symptomatic relief, with antipyretics, analgesic, antiemetics, focus on the hydration, vaccination status, and nutritional assessment, particularly for the children. Vitamin A supplementation may aid in wound healing. Skin care and secondary infection prevention. Supportive treatment for mild skin rashes to reduce the irritation. Consider the antimicrobial agents for suspected secondary bacterial infection like streptococcal pathogens and Staphylococcus aureus. Monitor for the complications like cellulitis and abscesses. For the management of high-risk patients, high-risk groups include the children, especially under the 8 years, pregnant women, immunocompromised individuals, those with poor skin integrity. Hospitalization for monitoring and potential antiviral treatment is recommended. Severe disease indicators, confluent rashes, or over 100 skin lesions. To treat the severe monkeypox, monitor and treat the progressive illness and complication is mandatory. Complication will be severe dehydration, pneumonia, encephalitis, ocular lesion, and sepsis. There are various antiviral agents are available. First is a tecovirimat. It has a mechanism, it will inhibit the orthopox virus spreading by blocking the P37 envelope protein. It will prevent the formation of cell-associated enveloped virion and extracellular envelope virions. It is important for viral egress and dissemination and effective in animal models. Optimal dosage found to be 10 mg per kg starting on day 4 to 5 post-infection. Dosing for infants and children under 13 kg is not yet established. It is approved by FDA for smallpox, monkeypox, and cowpox. Clinical efficacy of tecovirimat is phase 3 trial validated safety and pharmacokinetics with a regimen of 600 mg twice daily for 14 days. There are no adverse events reported in recent monkeypox cases in the UK and US. Shorter symptom duration noted. There are brincidofovir and cidofovir is also available. Cidofovir is an emergency use of smallpox, but has nephrotoxicity and lacks oral bioavailability. And brincidofovir is an oral formulation. with improved safety profile approved for the smallpox treatment. Efficacy and safety of brincidofovir. It has a poor efficacy in recent monkeypox cases in the UK. Mild liver enzyme elevation observed and synergistic effect with ricticovir noted. Vaccine globulin. It is developed from the vaccinated donor's plasma, provides a passive immunity against the pox viruses. It is approved for vaccination complication and recommended for the severe monkeypox cases. It is available as an IV formulation. Complications and sequelae of the monkeypox. Most monkeypox cases resolve within 2 to 4 weeks, and severe complication includes the encephalopathy and retropharyngeal abscess. Other reported complications are secondary infections of skin infection, sepsis, bronchopneumonia, encephalitis, corneal infection, and deep abscesses. Common long-term sequelae of the infection include the pitted scarring and vision loss due to the orbital infection. In the prevention of the monkeypox virus, individual and household prevention includes the hand hygiene, frequent washing with soap and water, avoid sharing the personal items that could harbor the virus, isolation. Infected individuals should isolate until lesions crust and new skin forms. Quarantine may extend up to 6 weeks after the exposure. Caregiver guidelines include the maintain distance from infected individuals, wear mask and disposable gloves, be healthy and vaccinated against the smallpox. Environmental controls, disinfection, use appropriate disinfectants on surfaces, wash the patient's clothes and bedding at 60 degrees Celsius, and securely waste disposal should be in the securely bag and disinfect the patient's waste. Prevention during the pregnancy. Cesarean delivery recommended if genital lesions are present. Newborn should be monitored for the symptoms and tested for the viral DNA. And breastfeeding decisions should be individualized based on the maternal health. Healthcare setting protocols. Precautions, contact and droplet precaution for the healthcare workers. Proper PPE usage, personal protective equipment required, and active surveillance for the exposed healthcare workers. There are available vaccination for the monkeypox. According to ACIP guidelines, pre-exposure prophylaxis recommended for the high-risk groups. High-risk groups include healthcare workers and laboratory personnel. Available vaccines are ACAM 2000, over 100 million doses in the US, and Jynneos vaccine, more than 1,000 doses in stock. Global stockpile includes approximately 2.4 million doses held by WHO. ACAM 2000 Vaccinia, replication competent vaccinia virus vaccine, and is licensed by FDA in the 2007 for smallpox prevention. Administration is a single dose via bifurcated needle, and efficacy is high protection against the monkeypox in animal studies and clinical trials. Safety profile of ACAM 2000 is there are common adverse events like mild reaction and severe adverse event. There will be progressive vaccinia and myocarditis. Screening will improve the pre-vaccination screening, can reduce the risk, and contraindication include the contraindication recommended for those without immunocompromised states or atopic dermatitis. Jynneos vaccine is a live attenuated vaccine derived from the modified vaccinia virus Ankara, approved in 2019 for smallpox and monkeypox, and in administration, 2 doses of 0.5 ml subcutaneously 4 weeks apart. Protection timeline is immunity develops 2 weeks after the second dose, and in safety profile, no cutaneous responses, safe for those with contraindication to ACAM 2000. There will be better cardiac safety. No myocarditis or pericarditis is reported. Recommendation for Jynneos. Booster shots are recommended every 2 years for high-risk workers and 10 years for others. And alternatives recommended for individuals previously vaccinated with ACAM 2000 and limited safety and efficacy data for children, pregnant women, and breastfeeding mothers. Clinical trial and future preparedness. Emphasis on the conductive clinical trials for new treatment agents, vaccine efficacy and safety, and preparation for future epidemics through the enhanced knowledge and research. Thank you.
Thank you, Dr. Lesha, for elaborative description about monkeypox. And we are also having a lot of questions, but let us ask our expert first his comments on this review article. Dr. Amol Jai Bhai.
Yeah. So good evening all, and thank you for the opportunity. Dr. Yesha has presented very well this comprehensive topic in a very crisp way, and she has covered most of the things in this article. Basically, like smallpox was eradicated around 1980. The last case was found in Somalia. So after that, the vaccination has gone down significantly, and that's why this kind of a zoonotic diseases has now a resurgence. So most of the epidemics, whatever happens, those are more of in Central Africa and West Africa, and now since 2022, it has been spread more than 50 countries almost. And India also, we reported more than 30 cases. So most of them are travel related and exposure history. So because of the globalization and traveling, and two states mostly, Delhi and Kerala has reported the cases. So if anyone is having any questions, I can ready to take it.
Yeah, any questions on YouTube? Pallavi ma'am? पल्लवी मॅम युट्यूबवर काही क्वेश्चन्स आहेत
Yeah.
का?
See the chat box.
नाही मॅडम नाही
Okay, okay. So my question about monkeypox is, what is the age group where we are pediatrician, we are saying from 1 day to 18 years or up to 21 years of age. So in which age group we should suspect that it can be?
It can present in 0 to 15
So
years of...
whatever.
Sorry, sir.
No issue, you can say. So see, there is no any restriction to the age group. So if you see the previous study about it, so most of the cases has been found in adults, and there are children involved less than 15 years, 0 to 15 years. There are at least, I think there are 3 to 4 cases of vertical transmissions are there. So that is only data available. So there is no any restriction to this monkey mpox virus. So it can affect any age group. The severity is more in a pediatric age group because of the clade 1. It has been found the usual case fatality rate because of the clade 1 and clade 2 is different. So clade 1 is more around 1 to 10%, and clade 2 is around 0.7%, but maximum reported case in 2024 is around case fatality of clade 2 is around 3.74%.
Yes, sir. This program is mainly for our practicing pediatricians of periphery. So my basic question is, when to refer to a ID specialist like you? So does the basic immunity, apart from vaccination, matters in these cases?
So basically, this virus affect the T cells like CD4 and CD8 cells, and basically, Dr. Yesha has shown a chart where she has shown some differentiating point between the measles, chickenpox, hand, foot, mouth, and mpox virus. So the classical symptoms of mpox virus is more of a fever with rash. Most of them, everyone will get, and more involvement of usually a symmetrical or asymmetrical lymphadenopathy that includes more of a cervical lymphadenopathy, axillary, and inguinal. So if you see the more vesicles, like pustular lesion, vesicle lesions, and scabbing seen. So these are the pathognomic rash you will find in monkeypox associated with the lymphadenopathy. Rest of the things like chickenpox, those will not have lymphadenopathy, and the difference is chickenpox is more of a centripetal. This disease is more of a centrifugal. So all the rashes you will found more on the face, palms, and soles. So that is the main difference. Um, uh, as there is no much of severity, and we have not seen any cases as of now in Maharashtra. So it is all more of a symptomatic management, antipyretics and other things. There are drugs like she has explained, like tecovirimat and cidofovir, brincidofovir. So brincidofovir is not available in India, but cidofovir is available in injectable form only, and it's a costly drug. Generally, we can use it, but more in a immunocompromised patient rather than immunocompetent patient, because it's most of the time it is self-resolving disease.
Yeah, thank you very much. And the second question is for Dr. Itkar. Will human milk banking help the working mothers of low birth weight and very low birth weight for continuation of mother's milk for longer time? And
See,
how we can increase that?
till now, all the milk banks which are available in Mumbai, they are mainly catering to the in-house and mainly admitted babies in NICU. This type of milk is not available for other NICUs also. So suppose I have our closest milk bank at Kalwa, Shivaji Hospital. They do not provide it to the outside other NICUs. So if it is not available to other NICUs, it's out of question to get at a home-based things.
Yeah.
Yes, if it is
That
available,
is
it is
main
going to be more.
limitation. Yeah, it's a limiting factor. Shall we proceed, sir?
Yes.
Yeah. Now I request our mentor, Dr. Mohanty sir, to have comments about journal journey and declaration of topics for 1st of January.
Thank you. See, these topics were selected basically, as you have already said, for our practicing pediatricians. The first topic about the research topic, it is actually doable in our setting. As sir has already clearly, Dr. Amul pointed out, if these preterm babies and non-preterm term babies who are low birth weight, if we can do in two separate groups and analyze separately this data, and in each private hospital clinics, if this can be conducted and all their data can be pooled, I think we can do it. This is the first of the kind. We do not have any other similar topic to compare with this study. This was done in Karnataka and Odisha in India and the African countries, the other side. So the almost if you analyze the Indian data with the African data, we'll see what the difference comes. But that paper has not separately analyzed and or written about it, commented about it. We can do it. This is one about this monkeypox. See, monkeypox has brought a scare. So we thought we should discuss it and hammer it out what is there. It is not to be frightened. We can handle it definitely, as you have seen in the topic. We can handle most of the cases nicely. I will just, I would like to, for my knowledge, I want to know, like in smallpox, we have been told that the lesions are umbilicated. What about the monkeypox? We are worried how to differentiate between this. We do not see smallpox, but in case this is our disaster coming, people are using biological warfare. We never know. We may see some cases in future. Anyway, we are at risk. So smallpox and monkeypox, can we differentiate between the lesions? Because the distribution is almost same.
Dr. Amol, please unmute.
Dr. Amol, please enlighten us.
Yeah. So most of the time, whatever rash we will get in a smallpox is umbilicated, but here you see the rash is variation is there. Means it is more of a vesicular one. and initially it is maculopapular and then pustular, and then the scab will form. So they have not clear-cut mention regarding the umbilicated or non-umbilicated in terms of this
Okay.
thing.
Fine. And no hemorrhagic form reported?
So there is a hemorrhagic form, means whatever the cases reported outside of India, they are like a hemorrhagic form.
Okay. Okay. Thank you. So
Yes, sir.
about the next month's topics, after this COVID, most of our children, school children, had to be homebound. And that I can see in my own house. COVID has gone so back, but these children are not used to get out of the home. So they are also asking for junk foods months inside this, and this NEET examination also worsen the situation. So for that we have selected a topic, old wine in new bottle, that is obesity, how it has behaved in post-COVID era and how it has been tackled, what the data says. That is one topic, that's a review article. The other will be, what is the Chitra? What is the other? Is CRP, C-reactive protein, its relevance in infection, and how seriously we should monitor that to limit our antibiotic use. That is a very relevant topic for our practicing pediatricians, and even including institutions also. We do not give much importance to CRP. We know the sepsis score and all, but as a part of that, we just ignore CRP. But CRP is very important, as Sir Amol Sir or Itikers will know, he knows that it is very important for the newborns, CRP, to indicate infections. So that will be another topic, the research paper. Let's hope to learn from that.
Yes, thank you very much, sir. And now it is time to express our gratitude to all the members, experts, presenters, and we are fortunate to have our Raigad IPER President, Dr. Vikas More, for that. Dr. Vikas, please do the honors.
Thank you so much, madam, for giving the opportunity. At the outset, I thank both experts, Dr. Itkar sir and Dr. Amol Vaidya, for their very practical analysis and how to actually transfer the knowledge to our routine pediatric practice. And more importantly, Dr. Ankit Mate and Yesha Parmar has presented it very beautifully. So made it the topic quite simpler. Though
very good, sir. Good job.
Both topics are quite relevant. Monkeypox we thought it is rare, but these days.
Yeah, connectivity issue.
Okay.
It is Sunday evening. Yeah.
Okay. So it is understood.
Yes, Sunday
After
evening.
this paper, I am started training my staff for a PEEP score.
What is
I really felt it is very important.
Oh.
Yeah.
So we are starting routinely now.
Hello.
It's in process, but in next few days, we'll start routinely PEEP score in our documentation part.
Great.
Hello.
Yes, please.
Yes, sir.
Hello.
Yes, sir.
So, the special mention of Dr. Itkar sir is a very inspiring personality. I came to know about him since last Dr. Ganguly sir, that how much meticulous he is regarding his NSU work and all that. And you will be surprised to know that sir has the whole data of last 25 years in his mobile. So can you imagine that? So this is a very inspiring for all pediatricians throughout Maharashtra or throughout India, I will say, how to do a very meticulous NSU practice. So I think we should get a presentation from sir, how to run a NSU practice. So that is a very from IB Raigad, definitely we invite him. And Dr. Amol is a very welcome addition to all those struggling pediatricians who are struggling with difficult fevers. And he's always there to help us. And today also he really guided very well. And now lastly, I will give a special mention of Dr. Ram Gopal Verma, sir, and Dr. Amol Pawar, who consistently help us throughout their tenure. This will be their last general session in their tenure. So I have no words to thank them because they supported us so that we can continue this journey. Lastly, Chitra Madam, Neha, and Pallavi Madam has definitely done their job to the best extent. And our own Niman Mohanty sir is a fatherly figure, always available. And thank you so much, everyone, for your kind participation. Thank you.
Thank you. Thank you, everyone. And thank you, Pallavi Dharmadhikari, for consistent support for this Zoom meeting. Shall we end the recording now?